alarm set for 4:55. Because I'm like, then I'll get up, I'll let the dog out, whatever I need to do. 5 o'clock,
Okay.
I fed the dog, let her out. Maya wakes up. She goes, can I have a book?
She wanted a book.
So in that case, she's awake. Like,
Oh my
she's not going
gosh.
back to sleep. She wanted to read in her bed. I said, cool, go ahead.
Have a book?
5 minutes later, okay, can you help me with this book? Okay.
Sure. Let me do that.
And then Peyton said, oh, I heard Penny, because I fed the dog.
Oh no.
And she was wide awake.
Hi everybody. As you can see, it's a little different than last time. 1, we're live, and 2, we're hungry. So, and we changed our structure a little bit here, which is probably going to change a lot over the next few. But anyhow, God, that smells really good.
It's fabulous.
We're going to all have that next time.
Oh, it's so good.
Okay, so this is the Inside Track podcast / live stream on Facebook and YouTube. Welcome. My name is Dr. Jamie Restack Applegate. I am a sports rehab PT and dry needling certified. And you are?
I'm Dr. Janet Yoder, sports PT, dry needling certified.
I am Dr. Haley Brown, also sports PT and dry needling certified.
And you'll probably want to talk just like a little louder.
Oh, yeah.
Because these are here. These are our microphones. We're working on it. Okay, so last week we got into a little bit about the posts I made on social media. And one of the things we talked about as we were kind of like getting into PT in general is we were talking about the gaslighting of bone on bone and the overprescription of surgery for arthritic pain. And one of the questions we asked during that conversation is we were talking about what is arthritis. So we wanted to answer that and also talk about how arthritic pain does not need to be a death sentence for you going under the knife and taking a year or 2 off of your workout or your volleyball league or your CrossFit gym, all of those things. It doesn't have to be that way, and you also don't have to just run it into the ground until you do need surgery. So we're going to dive into that a little bit today. So I'll let you guys start with this. But how would you describe arthritis?
When you said we were going to be talking about that this week, I was, in my head, I instantly tried to overcomplicate it because...
Yep, that's what I asked you just before we started. I was like, how much pathophysiology are we going to be going into?
Joint inflammation, like joint irritation.
Uh-huh.
Yep, a low level of chronic inflammation that can cause joint changes.
Pain, stiffness, yeah, range of motion restrictions with that.
And those are a lot of the symptoms and a lot of the, like, I guess, like, when I talk with, one of the things I talk about with my patients when I'm talking about bone on bone is and arthritis, is I talk about, like, what, like, physiologically, like what you guys were asking, like how physiological to get. I kind of take it down to its base function, which is like, it's literally the cartilage that's supposed to be separating the 2 bones and keeping them pain-free has worn down and the bones are now touching because the bones have nerve and blood supply, and that's what makes it uncomfortable.
Yeah.
Cartilage does not have nerve and blood supply, which is why we don't have any pain when our cartilage is normal. To put that into perspective for patients as to what's causing the joint swelling, pain, the inflammation, the irritation, all of those other things. So when we're talking about like more modern research on arthritis and exercise, what is it that you guys base your treatments off of? What's kind of the stuff that you are finding that's either some of the stuff we learned in school, things we found in practice, and new research that we're like, oh, I'm trying to incorporate this more because, like, this is helping me. So one of the things, I'll go first so that way you guys have some time to think. One of the things that is big in physical therapy right now is that if you have arthritis, we want to put you under load. And what I mean by put you under load is we need to start weight training and working into some plyometric training, which plyometrics is jump training. And for a lot of people, when they hear that, they're like, how am I going to be able to jump? I can barely walk right now, or I can't bend my knee all the way. we're not going to have you come in the clinic and then be like, oh, you're at a 10 out of 10 pain. How about you just jump over this big thing right here? How about we just jump off this step? Like, no. But we have really good research that working into that and tolerating more of that intensity is good for the joint, and helps the body compensate so that way it doesn't have pain with other activities as well.
Yeah.
So I have actually changed how I treat arthritis quite a bit, where I'm starting weight training pretty quickly when they are at a low pain level with just like walking and daily stuff, and then we can work into like more strength training. Because I've actually found that when I start, like let's say it's the first like 3 visits, we've gotten out of our intense pain with walking and our range of motion is near full, we start getting under like body weight and then a barbell or like a 25-pound dumbbell, like something in between if we need to, with depth squats or deadlifts to work on tolerating that. And if we're not tolerating that, we modify the movement. But the faster I can get them into some type of weight training, they usually feel better after those workouts than they did before we started it. So that's something that I've added to my practice that's more based off more recent research that I've seen just in the last few years that's become more well-known in the PT community, I would say. What about you guys? What are some things that you like to do? And it doesn't have to be like the full scope, like what you do at the end, like what I just said. It might be like how you handle at the beginning and
Right.
stuff like that.
Right. Well, I feel like my brain goes to the knee automatically a lot of times. So when I'm thinking of this, I try not to pigeonhole myself into the knee. But with the knee specifically, or any arthritic joint, I've traditionally done a lot of like joint mobilizations or work at increasing blood flow or reducing some of that stiffness that's a result of arthritis, to try to get things moving a little bit more so they're tolerating the pain, or the pain's more tolerable so they can move. And I recently did my dry needling certification, and in the research there, they were talking about arthritis as a lot of like a blood flow issue too. So thinking, I've changed my thought on that and like why I'm doing that. It's still applicable, all those treatments that I'm doing, but adding in dry needling for arthritis specifically, the goal we're working towards there is try to bring blood flow to that area and kind of make sure it's getting well hydrated, so it's getting the good nutrients it needs.
How are they doing, like how did they talk about that in your dry needling first? Because you went sooner than I did. How'd they talk about bringing blood flow to the joint, like an arthritic area? So we'll talk about the knee because like that's what we're talking about. Like, is it increasing? Because the synovial joints usually don't get a direct blood supply. It's usually around them. So how'd they relate that?
Right, so when you're making any mechanical stress to that area, you're getting blood flow stimulated, almost like you're increasing that inflammatory response in some way, which seems opposite of what you want to do. But
There's a healthy inflammation though.
right, there's normal amounts because that's how our body heals itself. And that's really what they talk about. It's like, well, if there's an issue with blood flow, why shouldn't we be adding something in that's going to help stimulate that blood flow differently, like it would be through dry needling? That's what I remember the most.
Yeah, hasn't been that long ago I took that class and I didn't remember that.
Yeah, they brought out the whole, I forget the like that, there's an arterial loop surrounding the knee joint, and so the protocol that we often use surrounds that area and tries to
that's nice.
bring that in.
Oh, so it's increasing the blood flow around the knee joint, so when you're bending and straightening it, it like does its squeegee effect where it like gets out all the bad, and then because there's excess blood flow, more oxygen, more nutrients, there's more to bring in. That's a conceptual thing for me.
Yep.
Okay.
The way I try to explain it to my patients a lot, I mean, they kind of covered everything that I would have said, but yeah, I definitely have changed the way that I treat patients in the last year and a half that I've worked here. I definitely used to be really cautious and conservative with weight training, giving people weights, especially with arthritis and lower extremity arthritis. But the way that I like to explain it to them is that our muscles need to be strong so that they're absorbing the forces that are being absorbed by the joint right now. So if we can increase strength with weight training of your quads, your hamstrings, your glutes, the force absorption is going to be a lot more comfortable there than through like an arthritic joint. So that's kind of another way that I like to explain it, or my goal with strength training.
Yeah. Yeah. And I would say, like, yeah, before you guys started here, did you do much? I mean, you just said you didn't do much strength training at all
No.
before.
But I worked in a lot of like
Not to this degree. What I thought was strength training.
Yeah.
Or, yeah.
Ooh, let's get into that actually, because that actually relates to the arthritic question, but it's kind of the basis of like what we do here in general.
Yeah.
But like when we were in school, were we ever introduced to a barbell?
Nope.
No.
Barely any exercise. They're like, you'll figure that out when you get to the clinic.
Right. The whole thing was pretty much almost always manual.
Manual, and then like, here's a few things you can do, but again, go to the clinics and you'll find
It was like all like
your stride.
anatomy, phys. Joint mobs were a huge focus.
Yeah.
For as much as we are not allowed to do manipulation, which for everybody at home, that's like the pop and crack, you get the chiropractor. There's a lot of state legislature that doesn't allow us to get to that point. In fact, you need a referral from a chiropractor to even be able to do it in Indiana. And in a lot of other places, like you need a referral from like a doctor, or you're just not allowed to do it because states don't consider it a part of our scope of practice. But we harped on like joint mobility a lot, which like there are levels to joint mobility that you can stretch the joint. So grade 1 to 4 and grade 5 is technically like the pop and crack, like a chiropractor manipulation. But I remember we focused on that a lot, like convex versus concave joints, and like how it moves anterior versus posterior versus lateral rotation.
What was that called?
We had arthrokinematics.
Yes.
Thank you.
We had arthrokinematics 1 and 2.
Right.
Like,
For
How much
class
do you use
just
it
for that.
now?
I mean,
I think of it
I
some
think
still,
about it
but
a lot.
yeah.
Like,
But I don't
especially when you
rely
get to
on,
the
like,
joints,
it
like
has
the
to be
proximal and distal,
distal.
like radial ulnar joints, or proximal
Yes.
distal tib fib joints. That one, I have to. It comes up. I feel like a lot more because that's not as natural
right.
of a thought process for me. But yeah.
Well, and I would also say that like arthrokinematics, like that study based, like studying that in grad school basically just taught us like how the joints move more than actual treatment techniques.
How to develop
For
the
sure.
treatment decisions.
Right. But like think about that when we were in grad school, like we learned a bunch of anatomy, phys, like what pathophysiology, so like what makes people sick and how it affects multiple body systems and things like that. And then we took a little bit of pharm, and then we went out on clinicals. Oh, we learned how to do a SOAP note, which is just our documentation, like how we put that together. But like we really didn't get any like applicable like example treatment sessions.
I feel like we got more in our neuro than we
Yes,
did in like
yes.
ortho. So we got a lot. I feel like I got a lot of ideas for neuro, but I don't.
Yeah, and
didn't
peds.
go in there.
Neuro and
Peds
peds.
is so short for us. It's just, and it's variable between schools.
Yes.
Yeah.
Yeah, and
We
it
got
just depends on the
minimal
therapist that you have on staff
Yep.
to teach. Yeah, and I also think about like I don't know how much time we would have actually had to spend on different treatment, like mock treatments. You know what I mean? Because you do learn a lot of it when you go out, but then again, a lot of your clinical like rotation, so where you're getting placed, like you're getting placed in a hospital system, you're getting placed in traditional therapy, and it's like we're eventually going to have students that come and see us here, but like that's going to be super rare. Like I don't know one place yet that does it in the United States, which means there's probably like a handful, but it's not well known for there to be a clinical like rotation for physical therapy students to go where you can like you can be at a gym setting and like teach people how to do those things.
I'm sure it's out there. I hope it's out there.
I hope it's out there. I would have totally gone to that. I would have fought someone for that clinical rotation.
We had a few in Florida,
Did you?
but they were only like 2 or 3 spots,
Right, you can't.
and everybody requests them, and
Right.
3 people get them, and it's just kind of the luck of when they place you and where they place you in your other ones. So I did, actually, fun fact, during my clinical rotations my senior year of PT school, that was peak COVID, and all 3 of my scheduled clinicals were canceled and rescheduled to other things. So that was.
What settings did you get then?
I ended up, my first one was like a not even.
What a
wasn't
nightmare. I'm so
PT.
sorry.
Um,
Oh.
But my
Oh.
second one was a hospital setting that was amazing. I learned so much. And then my third one was outpatient ortho with like a hospital system. I had a really good clinical instructor for that one. She was fresh out, was very up to date on a lot of things. So I felt like I learned a lot from her. But yeah, I was supposed to be at a child, like pediatric sports placement. And I was super pumped, and that got canceled because of COVID,
Yeah.
and then I didn't get to do it. But
Oh, that sucks.
Pediatric
Yeah.
sports. That's interesting.
yeah,
That
I
had
was
to have just
really
been like
excited.
under
Special.
18.
Yeah, it
like
was.
an-
I don't know if you've heard of the Joe DiMaggio clinics. down-
Mm-mm.
Yeah.
Sweet.
But anyways, yeah,
That's
So-
awesome. Yeah, no, we didn't have any sports rehab
yeah.
clinical
They just
rotations
wanted
where
you to
I
have,
went.
like general outpatient ortho.
Mhm.
That's what a lot of people got, or like.
I will say it is super important going through PT school. I did think it was super important to go through at least acute care for one rotation.
I loved my acute care rotation.
It just taught you a lot about how to handle and manage comorbidities
Yeah.
while being able to help people exercise.
Mhm.
And it makes ortho a lot easier when
Mhm.
you're seeing someone who's trying to exercise, but they have like diabetes and a stroke and a pacemaker and,
And a
they have
PICC
one limb
line.
cut off and like 4 lines coming out of them.
Yeah.
Because then when you get to ortho, they're like, yeah, I have AFib and high blood pressure. And you're like, yep, we can exercise. They're like, I don't think I can. Yeah, we can.
Yep.
I promise.
Yep. Yep.
Huh. Okay, so let's talk about arthritis in relation to like some specific sports. Let's start with runners specifically. And let's talk about like the hip. We'll do shoulder next, and we'll talk about like people who lift and stuff like that, or like gymnasts, which we haven't had a ton of gymnasts lately with upper body stuff. We have a couple with like back and lower body stuff. But anyhow, let's talk about specifically like hip and runners. So if a runner is developing some hip pain for whatever reason, and let's say they run a marathon, and then during their recovery 2 weeks afterwards or week afterwards, they start getting a bunch of pain. And let's say it's someone we've been seeing here, right? Like, so we kind of have been following their care and how they're feeling and managing lots of different things. If someone's like a week out and they've had this persistent pain, arthritic pain, like let's say 5 out of 10 just with walking for 2 weeks since it started. So that's 3 weeks post-marathon. How are you handling them when they first come in? Like, what's some of the first stuff you're working on? And do that while I grab my water. I'm out of coffee.
Hydration.
Oh, I thought that was your answer.
No.
You were
No,
saying
not
she's
sorry.
hydrating. Okay. Yeah. I think in that situation, I'm trying to figure out what they've done since the marathon, and kind of address those things, because typically those people, marathon runners, don't want to rest, don't want to do any recovery type things. Have you been resting? Have you been stretching? And, you know, not that you have to sit on your butt, but, you know, addressing their recovery, and then,
Or on the other
Right.
side, doing nothing
right,
because they're just done
right,
and sedentary and letting it stiffen up.
right.
But yeah, addressing
They're gonna have
whatever.
to flounder for a second. I need water.
Uh-oh.
Yeah, addressing the whatever they've got going on,
Yeah.
trying to
That can
reduce
be
the
a whole
pain
lot of
with
different things.
right without a specific case. It's really
Yeah, but
it's a loaded question.
I think about, I don't have arthritis, but I do have joint issues. And when I'm feeling crappy like that, I just need to move and get that fluid going through the joint. So I might do some range of motion or dry needling. Those kinds of things just always make me feel better. And that doesn't take a lot of strain to do those things. It's, you know, I might stand on that leg and just rotate a little bit, or yeah, anything to
Go
just
through some-
get more of that fluid moving through the joint,
Full combined body movement.
kind of oil it up a little bit.
Motion is lotion.
Yeah, so that would be my starting point, and I am pretty positive that that would probably knock out half of the pain just right there from doing that.
You know what I always forget when I'm in like the initial stages of an injury and I'm trying to give a couple things to like for people, I'm usually focused kind of what you're talking about with like pain reduction and then like range of motion and the start of some light neuro re-ed. So
Yeah.
like teaching the muscle how to work again after it's kind of
Yeah.
gotten knocked out from
Yeah.
like whatever swelling is, because that's, a lot of people don't know this, but part of the reason like when you have arthritis and you get swelling, let's say around the hip joint, muscles that, like when you have that inflammation from like an injury, not like healthy inflammation, it knocks out the muscles around it, and that nerve to muscle connection or neuromuscular junction gets gummed up and muscles actually turn off. And patients will like for the marathon example, they'll go out and do their light runs for like 2 miles and they're like dying, but it's because their glute hasn't been turned on the entire run, and they're like,
Yeah.
but I can do it, but I don't understand why I'm still having pain. Well,
Yeah.
your glute's not turned on because of the swelling, and then it's putting a bunch more stress on your hip, and so when
Yeah.
you go out and run, you're just pretty much jamming that bone together against the other bone, and it's making your arthritis worse.
Yeah.
So usually I'm working from that point, but I got reminded on social media the other day from another PT who was posting on sports rehab, and they were like, don't forget about isometrics. And I was like, yeah, I did though.
Yep.
Like there's the world's your oyster when you're rehabbing people, and then you see something, you're like, why haven't I done that in like 3
Yeah.
months?
Yeah.
This
Might get
person, this
band-aids.
person, this
Yeah.
person would be great for this.
Yep.
Why did I? Couldn't tell you.
Yeah.
Just hasn't been on my brain.
Yep.
I definitely cycle through things. And then
Yeah.
I'm like, wait, oh yeah.
Mm-hmm.
I don't know. It
Yeah.
seems like it fits. Something else fits for a while, and
Yeah.
then it's right there.
Or I think sometimes
That's a brain thing we probably should touch on
Yeah,
later, but-
we need any therapists want to come talk with us.
We are open.
Yeah, I think
do you retrieve
yeah,
the stuff back
I feel like I have to do
Yeah.
some like big fancy thing,
Right.
like to impress the patient, and it's like, no, why would I do that when this works and this is a simple little thing? But I'm like, I can't do that because that's too simple, or they've done that before, and it's like, well,
But
have
they
they
might
done
need
it
it
before?
again.
Have they done? Oh yeah, they might need it again, or have they
Right.
done it correctly? Have they?
Right. Oh my God, are you doing it correctly?
Yeah. So.
I
talked-
fall into
yeah,
that. Where
Yeah.
it's,
Talked to a lot of patients today actually about like fundamentals of just like, these are going to be simple things that you've done before. I know we've done it before, but going back and making sure like we're doing it correctly, we're retraining the muscle, mind-muscle connection,
Mm-hmm.
and getting that to work, because you can sit here and do a clamshell
Mm-hmm.
Oh yeah.
all day long,
Uh-huh.
but if you're not firing the muscle, or like if your TFL is spazzing out on that, it's not going to be effective, and you're going to be like, well, I did those all day, all like 3 days a week last week, and I didn't feel anything different. Well, we're probably not doing something correctly. So
Well, and let's talk about that actually a little bit. Like, we're talking about the mind-muscle connection. We're talking about like doing things, even easy exercises, mindfully. How often is it that you guys will see patients or someone will talk to us and they'll be like, well, like I'm doing all my exercise for my old therapy and it's just not turning it around.
yeah,
Or like I did some of the old stuff and it's just not like so how, like, and it may be stuff that you gave them before and they're like, so how is coming back gonna like change that for me? I want to use us as examples because we've been in therapy here before.
yeah.
You haven't yet. Hopefully you don't need it for a while. We'd love that for you. But you and I have come to therapy here before.
Yeah.
Let's actually talk about, as people who do this all day,
Mm-hmm.
we know all the crap.
Mm-hmm.
Why do we come and see someone? Aside from the fact that they can needle us and like I
Yeah.
can't needle the back of my neck by myself.
I could probably needle my hip, but I'm a chicken. So.
I would not, the way you get your needling done, I would not
No.
ever do that on
No.
myself.
Exactly.
Needle knee, maybe.
Right.
Hand.
Yeah. Yeah.
So aside from like the obvious stuff, like you're getting someone to needle you, what are some of the reasons of like, and you haven't done it, but you may have thoughts on like, why would you come see a skilled therapist anyways, even though you
As a
can do
skilled
the, as a
therapist.
skilled therapist
Yeah.
yourself?
Yeah. For me, I can only see so much. I only feel so much. I am a physical therapist, but I still have movement patterns that are habits, and just like any other patient. And so by having you look at what I'm doing and seeing things, it's like I never would have noticed that I'm doing that compensation. Or yeah, I can look at myself in the mirror, but I can't look at myself in the mirror from all angles. And so that's always just the most helpful thing outside of like the needling and the manual work. It's like you can see these things and you give me different ideas, like things that I would think to do for me as a patient are different than what you would think to do for me as a patient. And I just love having that extra perspective, and we can kind of like, it's just, yeah, just like any other patient therapist relationship, but we really like work on it together and kind of brainstorm ideas, and I just really enjoy that. And then I can take it to my other patients and be like, oh yeah, Jamie made me do this the other day. Now you all get to do
Have
it.
fun.
So,
And then the pattern of you're trying this thing and you forget about your old one.
yes,
And then you come back to it later.
yes,
Yeah.
yep,
Yes.
and then it continues.
Well, and that just gets into like there are multiple ways to like
Yeah.
do the job.
yeah,
Right.
oh, for sure.
I mean, that was one of the biggest things. So I don't know if any of you know this about me, but I'm a bit of a control freak sometimes, just occasionally,
No,
once in a while.
no.
But one of the biggest things I wanted to really focus on when I started hiring people to come work with me is that I didn't want to change the way they did therapy. There needed to be some commonalities between what we did, so that way there was a level of like expertise we wanted to start from. But I didn't want to say like there are some places you go and they have like if you start as a physical therapist there and they have scripts that you're supposed to follow and like an exact process that you're supposed to go through when you're doing an eval, and like a streamlined way of like so that way they can make, I mean it's a gray area, so as a therapist it can feel nice to like lean on that because like you don't have to think as much when you're progressing someone, but as on the other side of that you can't get creative, which is like the fun part of our job. One of the fun parts of our job. And as a business owner, you want the product to be all the same, but you're taking away from all of the like talent that you're like squelching by saying like this is the only way we do things. So that was one of the biggest things I wanted to create when I started the clinic, was like when I hired people, I wanted them to bring their own way, their own style of practice here, but it still be focused around like fitness, because there's so many ways to do fitness. And but I'm thinking about for myself in particular when it comes to like the reason I've come to see you guys. So I've come to see you guys mainly on like a prevention basis. I could like do all the crap. Like I'm trying not to cuss right now. We're like, but I'm trying to like I could do all of the stuff that I come to see you guys for if I was on top of it all the time, and I can't be on top of it all the time. Just straight up.
Yep.
Like I like the way it feels when I get needling done on my neck because I've had a history of tension headaches in the past. I don't have headaches from it now or migraines now, but like if I feel my neck getting tight, I'm like, I want to just go in and get needled because I know it's going to feel better and then it's going to help it go away faster and I don't have to focus on it for a few weeks. And I love that. I also find that like there are times, like I came to see you for my calves. I was like, yeah, I'm doing this and I'm training for this half marathon. And like, I don't know if my hips have anything, but my calves have been tight and I've got like some Achilles stuff popping up. Like, just take a look and tell me what I need to work on. And you were like, your internal rotation sucks. And I'm like, I know. I'm aware. But giving like me a couple things, because that's relating to like why things down the chain aren't working as well, right? Even though I'm like, yeah, I know that about myself. And it's like, yeah, but you should focus on it because like, when you land and your internal rotation sucks, you're basically landing in end range, and then that hurts more, and then you're putting stress in your calves, which is causing the tension. So there's this like cascade of stuff that like I'm not thinking about until like someone tells me.
Yeah.
And it gets to the same thing we were talking about, which is like it's buried back here somewhere.
Yeah.
And I'm focusing on all of you, but not on me.
Yeah. Yeah.
Yeah. Do you have anything to add with that? Okay.
No, it's been, I'm just hoping I don't get injured, but you know, it's inevitable that I will. Although, I mean, I didn't have to do anything specific for it, but if my neck would have kept hurting like it did like a month ago, I was probably turning around for that because that was miserable.
Mm-hmm.
So, yeah.
Yep.
Well, and let's get into that actually.
Also, it's nice to,
No.
nobody wants to be in pain. But as a therapist, when I have had pains or I can relate to my patients, it really does help.
Yeah.
Like oh, this
Oh,
is
yeah.
probably what that person was describing, and it felt better when I did this.
Yeah.
I should be giving that to somebody and not being so cautious about
Yeah.
something. Because a lot of times, there are times where like they're in so much pain. I'm like, okay, and it hurts to do this. Okay, let's do it halfway. But then I did it to myself. I'm like, it's fine. I know it's going to feel better. Why don't I have
Yeah.
my patients do that?
For sure.
Yeah.
For sure.
Well, and there's only, like, you're still trying to base, if you don't know exactly what their pain is like, you're
Right.
still just trying to base it off of, like, symptoms and what's going to help the patient. And, like, as long as it's helping,
Yeah.
that's the most important thing, right? But knowing, like, how much
Mhm.
to push is, it's nice to get that reminder sometimes.
Mhm.
Yeah. But let's actually relate that to arthritis. So we talked about arthritis in the hip, and then we talked a little bit about neck. We didn't get into shoulder as much, but let's talk about like examples of patients with arthritis in their shoulder who are like more active people. So it may be like volleyball players, CrossFitters. Every single CrossFitter who can't overhead squat should be listening right now.
Your husband.
My husband.
That's a different reason.
Accurate.
That's
Uh-huh.
not necessarily, I don't think it's the shoulder thing.
Oh, he says he's pretty tired.
No, but that's the thing. It's never the shoulder. It's actually your mid back, and
Yeah.
everybody's like, "My shoulder
Yeah.
hurts," and it's like it's because you look like a little hunchback. Like sit up
Yeah.
tall.
Like, I try not to do.
Yeah. Yeah. As we're all like, "Let me sit up tall." But let's talk about that in terms of a separate question. So like shoulder pain, and we're going to talk about lifting specifically or overhead sports. So like if we want to get into like a baseball or a softball example, tennis. I'm trying to think like track and field if you're a thrower. I have makeup on my face and
Basketball,
not do that.
kind of.
Basketball kind of like reaching up for a rebound
I think
or
of, like overhead. heavy
wrestling
Mhm.
or like jujitsu style stuff.
Yeah.
Football. So let's say like you have shoulder arthritis and you get injured doing one of those things. How do you help people figure out, and let's say it's someone we've seen before, how do you help them figure out like, because I've had patients ask me this before, when to come in for therapy and when not to? Like, because you were just talking about your neck, right? Like if it hadn't gone away, and then there's me where it's like, I just came in because like, I don't want to deal with it. But like, there are different levels as to why you would come in, why you wouldn't, and like decision making there.
Mhm.
So like, what does that, yeah, like how do you guys help your patients when they have those questions?
I think there's a timeline that we've kind of discussed around like what, like that 2-week mark or so, if you're dealing with an injury. It all depends on there's always the variables of like intensity of pain, of course, but if it's just a mild thing that's not really limiting you, but it's annoying.
And you haven't done anything about it yet.
Yeah, and like 2 weeks later, it's just not going away. You might have gone to PT before and tried some exercises. It's still not helping it, or maybe you Googled some stuff to do for, whatever shoulder thing you're dealing with. And then 2 weeks later, it's still lingering, or maybe getting worse, especially if it's getting worse. That's definitely indication that you might need a longer course of therapy. Yeah.
Does anything come to mind for you?
I mean, she hit it.
Yeah.
Would you say like 2 weeks? Is that too long? Do
I
you guys
usually-
think that's like a good timeline?
I
If it's
usually
not,
say,
if it's not improving at all.
Yeah.
Yep.
Yeah.
If it's starting to get a little better, you can keep trying. a few
Yeah.
things.
Yeah.
Yeah.
if it's someone I've seen before, I generally say 2 weeks because they've
Okay,
probably
yeah.
already jumped back on the things that I gave them earlier
Yeah.
to help it.
Yeah.
If it's someone I've never seen before, usually it takes 2 weeks for them to try anything to fix it.
Yeah.
And then if they're doing that for 2 weeks and it's still not getting better.
Mm-hmm.
And when we say not getting better, like what I mean is like your initial step is usually always to take a break from whatever you're doing that's causing the pain. So let's say you like take a week off or something like that.
Mhm.
And then you start going back and let's say over that week it started getting better, whatever, let's say shoulder pain. So if you're a volleyball player and you're having shoulder pain and you stop and let's say it's preseason, right? We don't have a game coming up. You take a week off where you're just doing like passing, serving doesn't hurt, so you still serve. You're doing weight training and weight training doesn't hurt, so you keep doing that. And then you start going back to hitting and it starts hurting again, maybe worse, maybe the same amount. And then you're like, okay, let me try, I'll go get a massage or I'll go get a chiropractic adjustment or All right, let me find these exercises on Google that are for like rotator cuff, and I'll start doing those for weights. And then the next week comes and it's still no better or it's worse. That's when I'm saying people should come in.
Yeah.
So like they've tried
Yeah.
these initial steps,
Yep.
and
Yeah.
they've taken the rest, they've done these other things to help it,
Yep.
and then it's still no better or it's getting worse as they get back to the thing that they want to do that they can't do
Yeah.
without pain.
Yeah.
A lot of times, like sometimes I'll talk with people and they'll be like especially patients that are leads who are like, I think I might want to come see you. And then I'm like, well, how long have you been dealing with it? Well, a few months. And then we start talking about like the kind of work it will take to like rehab and
Yeah.
like the time. And they're like, well, I haven't really done anything yet. And I'm over here like, y'all have waited 2 months and you're still not exercising the way you want to, and you think it's just going to go away by itself? Wrong. Incorrect.
Yeah.
But that's also difficult to like, that then you're having an entirely different discussion, which you guys don't have these discussions super often. You do sometimes. Like we all talk with
Right.
people in our lives about this kind of stuff, but it usually comes down to like, I mean, how bad do you want to get it fixed?
Right. What does it mean to you to be able to do that thing?
Yes. Actually, let's end on this and then I'm going to see if anybody else has questions. But I literally hate when patients come in and they're like, my main goal is I want to get out of pain. And it's like, okay, well, you used to play volleyball recreationally like a few years ago when this started happening. Do you want to get back to that? Well, yeah, but like, I just might be too old. I might be done with that. Like, I might not just be able to do that. Like, what if we tried? Well, if I can, that'd be absolutely awesome.
That's a goal then.
Cool. Can we make that the goal then? And people get really hesitant on
Yeah.
this. And I think it's because if they try and fail, it's going to hurt more.
Yeah.
In here.
Right.
Yeah.
Because they actually have
Yeah.
to say goodbye. Where if they don't try, they can give themselves a confirmation bias like, oh, well, it
My
didn't
body
work
hurt too
out.
much.
My body's so old now.
Yeah.
Like, I just can't do it.
Yeah.
Yep.
Like, and that's a huge one with arthritis specifically. Because it's
Sure.
like, oh, it's an old person's disease. And I just can't do it anymore. I'm going to tell y'all right now, I've had meniscus surgeries on both my knees. I guarantee I have arthritis in both of my knees right now. I have no pain. Currently, there's going to be some time where I'm going to cut or move or lift, and it's going to hurt at some point, and I'm going to have to work on bringing that pain down. But, like, I'm not going to look at getting joint replacements until I absolutely have to, if I ever need to. I used to say, like, 10 years ago, before I worked in this job, I was like, yeah, I'll need joint replacements one day. Now I'm like, why?
Yeah.
Why?
Yeah.
That should be the
Yeah.
expectation.
Right, exactly. It's
Yeah.
like the mindset. If it
Yeah.
comes to that, I'm not opposed to it. Like,
Yeah.
I want to
And
still
you'll
live
do
my
great
life
because you'll
You
know what to do.
and
Right.
you're fine.
and have done all of this stuff
Yeah.
beforehand. So when I get it, it's like, I'm not dying.
Yeah.
Right? Like, we
Yep.
saw someone today like that.
Yeah.
Like, he has waited as long as he possibly can for this replacement, and now he, like, got it, and he walked in 3 days after this surgery.
40, not even 48 hours.
Yeah, no device, no walker, no crutches. Like,
Carrying
it was
I think.
slippery, so he was
Yeah.
carrying them. Yeah. Yeah, but that's amazing.
Yeah.
Right? Like, he
Yeah.
did as much as he could,
Yeah.
which is awesome.
Yeah.
So, anyhow, that's not, like, do you guys have any examples like that of, like, patients that you've seen where,
Yeah.
like, it's a mindset thing and they're just like, oh, I just probably won't be able to do it. And then you're like, why?
Yeah.
I feel like sometimes my patients personally get annoyed with that. Comment if you agree.
Yeah. Yeah.
Yeah. I've had people say that, or
And remember, we're live, so change the story.
yeah.
You'll notice on the
I'm-
last one, we didn't get very specific.
Yeah.
Well, I had an
Was it a
example,
he,
but this
she, or they?
person.
Yeah.
Well, I guess this was a person that I had treated a while back, and she was very motivated though, so it doesn't really apply because she was like, "I have arthritis. I want to keep hiking." Kept hiking, which is great. And then it got to the point where it just it was giving out. She needed to, but she put the work in, and her recovery was so good.
Yeah.
And I think I just recently saw her traveling the world
Good.
on Facebook. Yeah,
Love
That's
that.
awesome. That's awesome.
feeling good. But yeah, I'm trying to think of an example where I've had to talk somebody into wanting that because I mean, this particular knee was.
Yeah.
That bone-on-bone description,
Mm-hmm.
and she was still doing a ton the year before, like a whole year before it just got to the point. She had another injury, and
Well, you know what's crazy to me too? Like,
she had done all the things, got
Right.
back to it.
yes, like
Just-
using that as an example.
Mhm.
It's interesting to me. So like, she had the mindset where she was like, I'm just gonna do it as
Right.
long as I can.
Right, but doing the work to make sure she
Yes.
could do it.
Yes.
It wasn't I'm
Yes.
gonna run it into the ground, I'm gonna need that eventually. It was like, I don't wanna do it, but it came down to it. She
Approximately how old was this person?
Like decade?
did. Like
What decade?
60, 70,
Yeah.
Wow.
Yeah.
That's amazing.
for sure.
Goals.
Goals.
Probably closer up to 70, yeah. I'm super impressed by her.
Yeah.
All
That's
the things she
amazing.
could do the year before when I'd seen her, and then the year after when it got to the point where it's like, well, yeah, it's probably the time now.
Yeah.
That's awesome.
Yep.
But the interesting thing to me is she had the mindset for that already.
Right.
Mhm.
So getting people to that mindset.
But how many people do we see who like they are just like, oh, the doctor said I need surgery, so I guess I need surgery. And then because I've had patients where they're like, I don't want surgery right now. But then when I tell them like, yeah, we just need to like we need to eat a little cleaner, we need to drink some more water, we need to get a little more sleep, and we need to weight train. And they're like, it can't be that easy. No, the hard thing is the easy thing is the hard thing.
Yeah, it's hard. It is hard.
It's hard to do all the things I just said.
Yeah, because everybody would do it if it was easy.
Exactly, because the actual easy thing and the reason we do so much surgery, the easy thing is to get surgery.
Yeah. Yeah.
But nobody sits there after they recommend surgery and are like, hey, by the way, you're going to have to at least take a year for that knee to feel. Let's talk about the hip.
Right.
Go back to our
Hip,
hip example, right? Like a runner.
Mhm.
Or shoulder. Shoot. It's going to take a year. Don't even get me started on a
I was
shoulder.
gonna say, it's
You
gonna
won't
take-
lift again if you get a
Yeah.
shoulder replacement. Like,
Yeah.
they're straight up
I mean,
like now they're taking off 25-pound limit, but just 5 years ago is like you can't lift over 25 pounds.
Mhm. Yeah.
Gosh, you're just gonna be
Forever.
in pain forever, aren't
Yeah.
you? That's not even body weight.
No.
Anyhow, but getting back to like,
Hip.
let's say like a hip replacement, right? Like they don't sit there and they're like, okay, so we are literally, if they do an anterior hip replacement, which is probably like the nicest one, like in terms of like recovery and pain,
Mhm.
they're gonna be like, we're gonna cut through here, which is gonna go through about 6 layers of tissue, including one muscle, and then we're going to cut through your joints, and fluid is gonna leak out. I mean, lots of fluid is gonna leak out, but your synovial fluid specifically is gonna leak out. We are going to shave off the head of the femur. We are going to grind down literally with a bone grinder to create a hole.
We're going to
Hammer
a new
in
new-
Two new, like if, I swear to God, if some of these
Watch the
grandparents
video first.
watched the video first,
before you decide.
nobody would get the surgery. Like, and did you guys get to watch a joint replacement surgery
Mhm.
ever?
No, I haven't.
You gotta find somebody that
Oh
will
man,
let you sit in on that.
I saw a knee and it was
I
just
was on
my
like,
friend
Yeah,
I
I
was
only
telling
saw
you
it.
about.
and this was like,
I bet I could ask him. He probably would let me come in on it.
you
go,
should
I should
yes.
ask him.
do it.
Yeah.
The hip
No.
was hard to see because there's a small field and there's so many people, but there's
Yes.
a screen I could watch from,
Yes.
but because I couldn't just be right there.
Knees are
Yeah.
gnarly
Even
though.
then, I believe it.
There's no good way to do
Oh,
a
it makes
knee.
me wanna
They just
vomit.
retract that crap out and then they like chop it off and then when they're hammering it in, it's like bent like this on the table and they're just like bam. Like someone's like 65-year-old grandma
Oh
is
my
sitting there like
gosh.
getting her leg, and then people can't understand why they're in so much pain afterwards.
Yeah.
I'm like, the bone bruise is gonna hurt worse than the actual cutting.
Yeah.
Like just the like wham, like the reverberations through the whole body as someone's nailing this implement, and then it's titanium. So if you ever fall and break your leg after you get a hip replacement, let's say, the metal's stable. It's not moving. Your bone is shattering around the metal. Now, nobody wants this. I'm not saying like this happens to a lot of people. That's not what I'm saying.
A couple years ago
Oh God, that's so
on
awful.
her knee. Yeah.
It is common in car accidents though.
She slipped on some ice and
Oh, dude, be careful on this ice. Winter is the worst for like humerus fractures,
now, but-
head of the femur fractures,
Yeah.
like,
yeah.
oh.
Anyways.
Yeah, that's a fun thought. Blech. Oh God, I can't even like. the surgery required to fix that.
Yeah.
Oh God, ugh, that makes me sick just thinking about it.
Yeah.
I'm sweating. I'm sweating. But like, yeah, like if we talked about all these things and then we said like, okay, it'll take you probably a month to walk by yourself, and then it's going to take you 6 months to feel like you can take stairs and do all the things around the house, and then it's going to take a year for that hip to feel like it's yours, even if you get back to exercise before then. And you might be able to start running before then too, but if you start running too soon, you're going to get a hip flexor tendonitis or an IT band syndrome,
you
and they
do
may
not
change.
want hip flexor tendonitis, y'all.
Oh,
Let
not after
me
a hip
tell you.
replacement. Oh God,
Let me tell you.
you don't want it ever.
You don't want it ever, but.
Ugh. But like, they don't tell you like, okay, and it's going to take 2 or 3 years for that hip to feel like yours again. And like to feel like it's not a problem.
Mm-hmm.
But you are always going to have something that's not turning on right, or excess inflammation with something. Like anytime you push your body, it's now like when you get surgery, it's now a new injury. And your body didn't like, it isn't made to handle that, you know? So that's one of the things, and I've told you guys this, like, that's one of the reasons why I push so hard. Like, I'm probably someone that you guys know in the therapy world that pushes against surgery much harder than most people. And the reason is that, like, your body's literally not made to handle that, right? We've gotten better at it, don't get me wrong. And it's not that people don't need surgery. Like, I've had patients that need to go get surgery. It hurts me inside, and I think about it for days, but it's necessary. But, like...
Shows that you care.
Yeah.
I get you.
Yes. But like it's interesting when people just think like, I just want to get this fixed. And it's not fixing it. In fact, what would be best for a person who's dealing with a body part that's giving them pain repeatedly is to just know that you forever are going to have to take care of that body part. You're not always going to be injured and incapable of doing things. That's not what I'm saying. But you are always going, like when you are pushing your body to do something, like you're training for a marathon the first time, or you are trying to get a new PR in your back squat, or you're trying to do a handstand push-up or a pull-up, that body part that has been giving you pain in the past is going to continue to flare up when you try to push your body.
Yep.
Because it's the weak spot. Like it's not as strong as the rest of you. And that's not a bad thing. But like, let's be clear, like you're not going to fix it forever. Mm-hmm. But also, we never leave this life unscathed. If we did, it'd be super boring.
Yeah, true.
Like,
think about my skiing accident.
Right. You did that? Like, that sucked. I remember getting that call from you on the top of a mountain, and I'm like, first, how do you have service for this?
Why
And
are you
second of
calling
all,
me first?
right. She's like, I might not be able to work on Monday. I'm like, that is the least of our problems here. Have we called a doctor yet?
Yeah.
Oh yeah, is your Jimmy John's here?
Beach Club, number 12.
Oh, I love the Beach Club.
Yep.
This is not an advertisement for Jimmy John's, but we are advertising for Jimmy John's. All right, let me see if we got any comments. Someone actually said hello on YouTube. Which I was
Someone said hello?
Yeah.
Oh, cute.
I loved it. Okay, we do not have any comments right now, which is totally fine. So I think we're just going to be done.
Are we doing a challenge? Is that
I don't know if that's going to be on.
Not live.
That'll be for
What?
Facebook or for social media later. Are we doing our mobility challenge today?
Oh yeah, we are going to do our mobility challenge today,
Yeah.
but we aren't
Not
necessarily
on
going to do
live,
it on
yeah.
live.
Yeah.
I mean, we could. We can if you want
No,
to.
we can't edit that.
Nope.
All right. Well, we really appreciate having you all and that you would take time to watch this and listen to this. If you have any thoughts about what you would like us to talk about and that you're interested in hearing about, you can either comment on one of our videos, because I check those pretty much daily to see what comments we get, and we will cover that in one of our future episodes. Or you can send us an email at insidetrackpt@gmail.com. But other than that, I hope you have a great weekend. It's supposed to snow this weekend.
I don't mind snow in December, but it's a little early for me.
You guys won't see me next week. It'll just be these two.
Yes.
Still do this?
I'll be
all right,
in
all right.
Florida.
It's gonna be us holding down the fort.
Yeah, maybe
Yeah.
I'll tune in and harass you guys.
Oh,
Go
man.
anonymous and ask some questions.
You should totally do
Create a
that.
fake account.
Should have just said it. Now I know.
Now we're gonna know who it is.
What
We'd
if
be like, who's asking these stupid
Yeah,
questions?
yeah.
Thanks. Anonymous walrus or whatever.
Anonymous walrus. Now it has to be that.
Oh, maybe it will be, maybe it won't.
So anyhow, thanks for joining us. Have a great weekend. Peace. I'm not doing. This is
I know, I
an
wasn't-
inside track. I'm not
I
doing
wasn't gonna say it.
that. All right, and
That's for the next L10.